Now I want to introduce our speaker for the session. John Dow is a partner at Wipfli's Healthcare Facility and Capital Planning Group with over 2 decades of consulting experience. He has worked across the country assisting healthcare clients to plan and finance new facility developments and renovations. John also leads Wipfli's board of directors. John's career has spanned a wide breadth of hospital and ambulatory settings, ranging from large academic hospitals and integrated delivery systems to small regional and critical access hospitals. So we'll welcome John.
Thanks, Kale. Can you all hear me? Fine? Okay. If you don't mind, I'm going to kind of walk around up here, get my steps in. Important for health purposes, and my watch is tracking me. So I'm going to be speaking about rural healthcare today, which is a subject that's near and dear to my heart. Wipfli is a top 20 accounting and advisory firm. We work with many critical access hospitals across the country. I have the good fortune of being able to help many of them plan and implement facility master plans, and which ultimately end up in new buildings, hopefully, new clinics, new hospitals, expansions, etc. And so we're going to talk a little bit about that today, and how if you're rural, this is going to speak right to you. If not, and you're a larger health system, you probably own or manage some rural healthcare facilities. So in the entire health ecosystem, rural is very important because it provides access to many people that don't live in the major metros. So the agenda today, we're going to talk a little bit about just the overall state of rural health, where it stands today. And then we're going to go through a methodology that we feel is very successful in helping rural healthcare providers diagnose where they are financially today, and then set up a plan for the future on how they're going to reinvest in their facilities, because many of the hospitals that we work with are reaching 50 to 60 years old and need replacement. Then we're going to go through the actual process of what's a successful facility master plan look like, what are the things that key components that go into it. Then we're going to talk about financial affordability and what are people that are giving out loans to pay for these projects are going to be looking at, what are the important indicators and metrics for financial affordability, because without that, you're not going to be digging any holes or doing any type of construction. So let's talk about the state of rural healthcare. This is just a little bit of a history lesson. The blue circles can be kind of indicated as things that were positive. In 1946, the Hill-Burton Act was funded, which allowed construction for public and not-for-profit hospitals in rural communities. And then the 80s and 90s came the PPS reimbursement rates, which really knocked down the ability of those hospitals to stay open. And many of those rural hospitals closed between the 80s and the 90s. And to help fix this, in 97, CMS implemented the FLEX program, which allowed for cost-based reimbursement for CAHs, which really was a boost and helped many of those rural hospitals stay open. Unfortunately, in 2020, COVID happened, and again was more serious headwinds because people weren't going to the hospital, volumes went down, massively impacted the industry, especially in rural areas, and then that caused 19 hospitals to close since 2010. Now today, we're faced with these hospitals that are, like I was saying, 50 to 60 years old, reaching the end of the useful life, and financial pressures continue to mount with the big, bold, beautiful bill, the cuts in Medicaid, the challenges with 340B potentially as well. Those are all major headwinds facing rural organizations today. So what are the factors that are driving hospitals when they close? The first is declining market share and patient volumes. Many of our rural hospitals service communities that have population bases that are either flat to declining, and that obviously has a negative impact on volumes, which reduces reimbursement, reduces revenue coming in for our rural hospitals. And with the reduced revenue, there's obviously financial pressures, declining margins. The relief funding that they got during COVID has dried up for the most part. And then just challenging payer mix and just the overall cost to deliver healthcare continues to rise year over year, whether it be staffing, supplies, et cetera. And they're just staffing shortages in general. We're talking about nurses, doctors, providers. A lot of them don't want to live out in rural areas, or there's just not a big supply of them. And because of those first two things, there's been a lack of reinvestment in facilities. So the hospitals are struggling to keep their days of cash on hand up. Their margins are down, so they delay investments in things like infrastructure, and just the hospitals are getting to that age where they need some replacement. Otherwise, the cost to operate them is just going to continue to drown the facilities. So Wipfli, every year, we survey a bunch of our clients to kind of get an assessment of where they feel they're at. And while we learn that, there are certainly headwinds and there's bad news, there's a lot of hope and optimism based on the respondents. And these are all leaders, CFOs, CEOs of critical access hospitals across the country. Some of the key findings that we discovered were that 96% of rural healthcare organizations are actually optimistic about their financial viability going forward. 41% said that they have significant financial concerns and reimbursements, which is actually lower than what we had thought when we'd sent the survey out. 78% are not at all likely to consolidate or merge with another organization, which is another healthy sign from a financial perspective, because usually when they're looking to be purchased, then it's because they have financial issues. Cybersecurity was continually mentioned as a top concern, which is up 50% from prior years. And most have increased their investment in cybersecurity because of that concern. And only 32% are actually using AI tools, which everybody's still trying to figure it out, actually. We still, as a firm, are trying to do that too, but only 32%. This is kind of a trend slide that talks about just people's optimism towards their financial state versus 1 year ago, back in 2024. And as you can see, most of these numbers are going up from 1 year to the next, which is a positive sign. And then we also asked, how do you feel about your financial stability compared to 3 years ago, which was 2022 or 2021, 2022. And most of those are going up as well. The ones that are not feeling as good is pretty flat to declining. So the leaders out there that we work with across the country are very optimistic about their future financial state. And that's what's driving a lot of consideration about investing in their capital stack, their buildings, their clinics, things of that nature. And I can attest to that. I'm currently working at about 4 different critical access hospitals in the state of Washington and Oregon in the Pacific Northwest. And what we do at Wipfli on the facility and capital planning side, if we're busy, that's a good sign for our clients, because we're like canaries in a coal mine. Like, we don't have a lot of work. It means that our clients are not thinking about reinvesting. So that's a great sign. Usually when we are approached by our clients, they all have similar struggles. They know that there's strategic growth opportunities out there for them in their market, but they don't know exactly what those are and how to quantify them. And if you can't quantify it, then you're just kind of going by your gut. And when you're talking about $1,000 a square foot for building new hospital square footage, that's a big gamble. They're also struggling with aging facilities. Talked about that. Hill-Burton Act hospitals are 50, 60 years old and falling apart. And what they really need is a strategic and service line development plan that ultimately leads to a roadmap for their facility development. And so that's what we're going to talk about today, the paradigm that we put together to help clients across the country and to educate those in the room that are thinking about this. What are the key things that you should be thinking about as you undergo a process like this? Because usually I like to call these projects once in a generation. You're not doing these every single day unless you're like Marnie and multi-care that's constantly building or something like that, or somebody from Providence. But a lot of our rural providers, when they undergo a project like this, it's once in a generation and they want it to last 50 or 60 years. So right out of the gate, one of the first things that we recommend doing for any client that is thinking about undergoing a major building project is to look at and do a comprehensive market analysis so that you can really understand what your future facility needs are. So there are 4 major components of a detailed market demand analysis. The first is understanding where your patients are coming from, or what we call population served. How many patients are you drawing? Where are they coming from? What zip code? Establish your primary, secondary zip codes, service areas. And then within those service areas, what are the demographics doing? A lot of our rural communities service much older population bases, but that's not always the case. We're working right now in a community that has a lot of manufacturing, has a lot of Latino population base, and they have very strong growth rates. But they're the exception rather than the rule. Most of our communities in the rural areas are flat to declining population bases. You want to understand market share and utilization trends for those service areas. So are your volumes going up? What are your competitors doing? The type of provider or supply and need that you have is ultimately going to drive the facility plan. Oftentimes, for whatever reason, when a healthcare provider wants to do a major building project, the first organization they call is an architect. In my experience, that's generally how healthcare should be, or how healthcare development projects kick off. So we're thinking about building something, that's called an architect. Now, that's kind of like if you're going out to buy a home, you don't go out and talk to builders right away. You talk to a mortgage broker. You figure out what you can afford and then design the building around that. Healthcare has always been backwards that way. In my entire career, I've been trying to educate people and healthcare leaders that it needs to be more robust on the front end of planning before you call an architect. Not that we don't get along with architects. We work with them every single day. They are strategic partners of ours. But a lot of times, in my opinion or my experience, architects rely too much on the qualitative data, the left side of that chart there, where they'll sit down with healthcare leaders and say, well, what do you want? What do you need? And then they'll build a master plan based on that. And of course, you're going to meet with people, you're going to interview them, they're going to give you their wish list, not necessarily based on anything that's reality or data. So our approach combines both qualitative data, which is the interviews and tours and things like that, with quantitative data, where you should be looking at historical patient volumes, what your market share is, and then you should be benchmarking against all other critical access hospitals and rural hospitals. So combining the two really gets you the best product in the end. We're going to show you some representative slides of deliverables just to give you a sense of what it would look like if you were to look at this in detail. This is just an example of a age cohort analysis. So this client, if you look on their bottom line, that's their primary service area, and then their secondary service area, and it's broken out by the different age cohorts. We tend to really focus on the age 65 plus, because that Medicare population is really the ones that are the highest utilizers of healthcare. So we want to see if they are indeed a much older population base. And for this client, they are 21.6%, 22.4%, so much older population base compared to state and national averages. So we would expect utilization in this service area to be quite high. You should also be looking at market share trends. So depending on the state, most states have utilization data both on the inpatient and outpatient side. And at a bare minimum, you can get Medicare data that's nationally reported. But Medicare data that is always a couple of years old, it's blinded if you don't have enough volumes to look at it. So it's kind of crappy data. But most state hospital associations track all of this comprehensively as well. So looking at your inpatient market share trends, what has that been doing going forward? The chart on the right is really one of my favorites. This is an analysis that we did for outpatient surgery for a client, and we looked at really how much surgery was being generated by their service area, where it was going, what was their market share in it. And how you look at this chart is across the left side is the market share for that particular hospital. And then on the bottom, on the x-axis, is the number of surgical cases that the market is generating. So for this particular client, if you look at OBGYN as an example, they had like 80% market share, but the volume, the circle is actually kind of small. So while the market share was strong, they weren't getting a lot of volume. If you look at the bottom right, you see orthopedics is a huge circle, meaning there's tons of cases, and they only had about 15% market share on there. So this spells opportunity. If you look at that, if you look at ophthalmology, very low market share, decent sized volume as well. So while this client had strong market share in several service lines, the volumes are very low. So this indicated that there's definitely opportunity in that orthopedics market. Also, understanding provider supply is very important as well. Recruiting providers to rural areas is very difficult because, a lot of them, they weren't trained in the rural space. They want to work in the major metros. It's more volume and things like that. But understanding what your provider need is compared to the demand is one of the most critical things that you can do, because your primary care base is the most important lifeline of a critical access hospital. And if you lose one provider, that can cripple the financials of a critical access hospital. So understanding that and quantifying it will not only help you understand how big your rural health clinic needs to be or primary care clinic needs to be, but also, quantifying that workforce need. What you see here is most critical access hospitals, their family practice doctors do everything. So you see here that it looks like there's a oversupply of family practice based on need, but really the family practitioners here are making up for the shortage in internal medicine, OBGYN, and pediatrics. We see this all the time. Now, demand is a tricky thing in rural areas because a lot of times we see that the providers are not very as efficient. They're seeing 7 to 12 patients a day versus in the metros, you're seeing 24 patients to 30 patients a day. So that's something that needs to be baked into demand as well, is that your rural providers generally don't see as many patients per day, not as productive. So that needs to be built into the demand calculation. But if you are successful at recruiting a provider, it's very important to understand what their production level is and what it means for downstream potential additional revenue. So this is something that we put together for a client that was seeking to recruit an orthopedic provider. And as you can see, depending on how productive that orthopedic provider was at the 25th, 50th, or 75th percentile of MGMA standards, that generates a lot of additional clinic visits, x-rays, surgical cases, lab visits, things like that. So before just diving into something, it's important to quantify what that potential impact is going to be and what it could mean to the hospital's revenue and bottom line through that successful recruitment. And once you get a sense of what your provider needs are, that's when you can start to really look at future forecasting. And try as we might, we don't have a crystal ball. So when we look at forecasting utilization rates going forward, we use a kind of a low, medium, or high sensitivity. So we look at utilization in the past, project it forward, and then provide some ranges on the low or high end, because we know we're probably not going to, we're going to be somewhere in the middle. But to have some scenario modeling is very important so that you give yourself some flexibility up or down based on your future volume projections. Because when you do these projections going forward, we usually do 10-year projections because in this day and age, a construction project takes a minimum 2 to 3 years, and that's if you're going pretty well. And so, like, we were one of the consultants on the new hospital in Moses Lake. I remember that we started that project when I moved to Spokane back in 2017, and they just had their grand opening, I think, a couple months ago. So that's how long these processes can take. So once you understand your future utilization, then you overlay some assumptions on things like length of stay, turnaround, things like that. Then you get to actually convert it into inpatient discharges and then into inpatient bed need. So this is an example of a client where, as you can see, we did a baseline, medium growth, high growth, what their future inpatient discharges are going to be. We calculated how many beds they were going to need based on those discharges and patient days. As you can see, for this particular client, they had enough inpatient beds to support their future needs, which is something we typically see. Inpatient beds is usually never an issue for our critical access hospital clients. They generally have more beds than they need. It's a lot of the clinic spaces, outpatient ER space, things like that, other outpatient focused spaces. They're running out of space. This is one thing that in my 20 years of doing this in facility planning, if you talk to clinicians, they never remember the time when their department is really low or empty, like OB or ER. They only remember the times where they're short of space. So when you go through a facility planning process with them, they're going to default to that sentiment of, remember that time we didn't have enough. So I'm going to plan for X percentage more than what we actually need so that we don't have to go through that pain of not having enough rooms, having enough. And ER is a very common thing where they need that. So if you sit down with them and have an interview, they'll say, well, we need twice as many rooms as we have. Well, what's that based on? Well, it's based on my gut feeling or based on what happened to us flu season of 2022 or something like that. So ER data, though, is very detailed, and you can look at when did they come in, what was their level of acuity, and what day of the week, what day of the hour of the day, what month of the year. And looking at the peak factors of the busiest hour, the busiest day of the busiest month, you can really get a sense of what that true Easter Sunday is, where it hit the fan and they ran out of rooms. And that's not what I'm saying that you should plan to. So for this particular client, in 2020, they had a peak room need of 10, and they had 9 total rooms. So generally, we don't plan to the peak because your rooms will be empty more times than not then. We plan to 80% of that peak. So there's going to be 20% of the time when you might not have enough rooms and patients need to sit in the waiting room or whatever, or be treated in the hall, but 80% of the time you're going to have enough ER exam rooms. So this is an example of how you kind of counteract that qualitative gut feeling that a lot of providers can have. This is something that many of our rural critical access hospitals are not good at, and that's understanding profit and loss by case, by service line. Many do not have a good sense, either through a lack of a cost accounting system or whatever, but they don't know which of their service lines are generating a bottom line and which ones are treading water and which ones are losing them money. So one of the things that we often have to do is, before we consider investing in something, how much money are we making on that particular service line? And is it worth, because not all volume is good, right? Volume is good if it helps resolve an issue for your community, but also helps to improve the bottom line for your hospital. If you invest in too many laggards, we call them, then you're going to continue to erode the hospital's finances and you're not going to be able to spend money on reinvestment. We have many hospitals that are consider net new service lines all the time. This is a particular one that was not offering gastroenterology as a they were having their general surgeon do all their GI. They wanted to invest in a specialist, a gastroenterologist. And so we suggested that they did a very detailed financial forecast for adding that GI doctor, how much it would cost from expenses perspective, and then what's the additional revenue, and then what potential income or profit would be on that investment. So anytime you get into something net new, you can't gamble. You got to do the due diligence to try to figure out what the return on investment will be on something net new. So now that we understand our market, what our opportunities are, kind of what our future key planning units are, that's when we turn our attention to facilities. So one of the most important things from a facility perspective, the market demand is going to let you know what your future facility needs are, but then you also have to do a very good job kind of benchmarking your existing state and understanding how you compare to your peers and documenting where your shortage areas are and what your pain points are. And that's because I work with a lot of district hospitals, and anytime there's any type of change to the hospital locally, and you need to go to the board or you need to communicate to the community, they're going to ask why. They're going to think that their healthcare costs are going to go up, and that why do we need to spend money on this hospital? It seems to be fine. Because projects like that, the supporters, they don't come out. It's the negative Nancy's come out to those public meetings to try to put down projects like this, in my experience. So really understanding and documenting the major pain points, whether it be infrastructure, space, design, whatever, is very important because it provides breadcrumbs. So when you're trying to rationalize a project to the community, it's very important that you document the heck out of the current issues that you're facing. Once you document and you understand what your future needs are, that's when the creative fun part of the process, and that's the facility options, where you're looking at either do we renovate what we have, do we make an addition, do we do a replacement facility if you can afford it? And then obviously cost estimates are very important as well. And with escalation and the tariffs and everything, we were seeing cost per square foot be anywhere between 800 to 1,000 plus in the Pacific Northwest these days. And when I remember starting this business 20 plus years ago, $500 a square foot was what we're using for new hospital construction. So it's increased dramatically. So it's a lot of money on the line for these projects. This is an example of an existing state floor plan for a hospital, and the different colors represent the different types of space that they are. And we like to see a lot of the similar colors next to each other because that would indicate that the departments are next to similar types of departments. You don't want support areas or you want public areas near non-public areas, because then you have wayfinding issues, you have privacy issues and things like that. And also you'd be surprised, many of our clients, they don't know who owns exactly what space. There's a lot of the squatters' rights going on where you find an empty room and you put up a cubicle, that's my space now, type of thing. And so really understanding where the departmental borders are and things like that is critical, because if you don't know where the borders are, then you can't really do any benchmarking or anything, or understanding what the total amount of square footage you have and who owns it. Something very simple, but you'd be surprised. And then benchmarking, once you understand how much square footage you are and you categorize it on things like inpatient, diagnostic and treatment, that'd be like your imaging, ER, lab space. Administration would be administrative space, and then your support space would be like your EVS, materials, things of that nature. There's 1,200 plus critical access hospitals across the country, and they all have different departments, and we work with many of them. And benchmarking against other similar sized critical access hospitals can really be eye-opening in terms of, do we have too much administrative space? Do we have too much support space? Because those are areas on the cost report that are not reimbursed very well. So are there ways that we can reduce that space and focus on some of the more clinical areas. And this is just kind of gives you a guideline of where we are from a distribution perspective at a macro level from square footage. Then you can do a very detailed kind of room by room look as well. This is an example of, like, we looked at their surgery and their OR was 538 square feet. Benchmark right now is around 580 to 600 square feet. So for the most part, they're in pretty good compliance in that regard, but you can do it for every single clinical department and try to get a sense of where are they short on space. This particular client is actually doing very well. Their ER was in 97% of our standard, imaging was 86%. Some of the hospitals that we go to, we see these sometimes 50% below benchmarks. And those are kind of the red flags to us to say that this is not enough square footage compared to contemporary standards. So we need to address it as a priority. This is an example of current versus future square footage need. So this bar chart reads, the blue is how much square footage they need today, and the light gray bar on the top is how much square footage they're going to need in the future, based on the calculations that were made for things like new doctors, getting up to contemporary standard and things like that. But this is a very important step because you're actually quantifying by department the future square footage needs, and that's when you can start developing plans to address those square footage shortages. Another thing that is very important, I mentioned documenting. This is a list of criteria that we recommend using as you're evaluating your space. Is it in the right location? Does it have the right design? Is there enough space? Are there customer service amenities like waiting rooms big enough? Is there privacy? Is it easy to find? Is parking good? And then at the end, do you have to provide an overall priority or triage? Because guaranteed, there's going to be more needs than what you can likely afford, right? So triaging where you spend those dollars to get the best bang for your buck is critical. This is an example from a hospital in Illinois that we worked with that actually built a replacement, and then due to growth and their own success, they started to outgrow their own space needs. So this is a chart that kind of looks at their hospital as a whole and document which are their departments that had high priority issues. So those are the red circles, and then the medium priority issues were like the yellow circles there. But this is a very simple and easy way for you to summarize kind of what the priority issues are, document like their lab, lack of space to support future growth and instruments, poor design, workflow, and makes it easy for someone, a lay person, like board member or somebody in the community to take a look at it and go, yeah, there's a lot of issues here, and probably something that we need to support being addressed. We also recommend summarizing or compiling all of these ratings. This is something that's like a consumer reports type of chart where you'd go through every different diagnostic and treatment area. Like first one listed there is therapy and rehab. Where is it located? Green means good, red means bad. So this particular rehab department had a great location, but it had poor design, space, and customer service. And is it a priority or not? Is it something that you feel like should be on the list to be addressed? And then the comments really document everything. So again, leaving breadcrumbs so that if someone were to pick up the plan, they could implement it and know why decisions were being made, how they were. This is an example of the square footage needs of a hospital that was considering a replacement. So this hospital was 104,000 square feet today. We actually, when they proposed the new hospital, the square footage actually went down by about 10,000 square feet. And the reason why this was because they had put their admin offices into an old part of their hospital that were old inpatient beds. So they had huge private offices with private bathrooms and things like that. So when we put them in more contemporary space, the admin square footage went down significantly. And there was another proposed on-campus option where they were going to keep some of their old hospital and expand out to that. But getting to a total net square footage number is critical as part of the process. And once you have those numbers, that's when the creative fun part of the process begins, and that's options development. So as you think about options development, that means like, what are the options that I can have to achieve those square footage numbers? And you can do a variety of things. You can renovate internally only. That's the right side of the left side of that chart. Or you can do renovations and add an addition to the building. Or you can build a net new building as well. Obviously, new building at a new site is the Cadillac option, the most expensive usually. Because you have the cost of not only the new building, but then there's site acquisitions. Depending on where the building's located, you might have to do utilities, sewer, water, and things like that. That can add up very quickly. So this is an example of a client that we worked with where they did kind of the middle option, where they did some expansion internally, remodeled their kitchen in that brown space there, added some servery space. And then they also built a major addition to their primary care clinic and added a rehab wellness center as well. So this gives you an example of kind of that middle option of renovation combined with addition. This is a unique example. You know, when we work with rural, we're always thinking about how do we maximize the bang for the buck and not overspend and not overbuild. So this is an example of a critical access hospital in the Upper Peninsula of Michigan. And they had needs for growth in the emergency department, and they also had needs for growth in the outpatient medical services. They had a very busy oncologist that came on Tuesdays and Thursdays to treat cancer patients. And when they were on site, they had massive congestion issues because she would stack up her patients all day long because she was only there 2 days, and they would run out of rooms very quickly. So both of those departments were like, we need 40% more ER exam rooms because of our peaks, and outpatient medical is like, we need twice as many rooms. So between the two, each was asking for 12 and 12, so 24 total exam rooms basically. And so we're thinking there's got to be a better way to do this as opposed to building all 24 new exam rooms. And if you think about the type of treatment space an ER exam room is and an outpatient medical exam room is, they're very similar. Similar size, similar technology and things like that in there. And so what we did was, instead of building 24, we built the two departments right next to each other and built a hallway or a door between them. And if you think about the ER, when it's busy, they were busy at night mainly. That's when the ER is traditionally busiest, on the weekends and nights. Their outpatient medical was busiest on those Tuesdays and Thursdays during the day. So we thought, well, how can we resource share? How can we share these rooms so that when you peak, that you're not necessarily having to build to that peak number, but that you can share the space. And that's exactly what they did. So ER is on the left there. At night, when outpatient medical is closed, because they're not seeing patients at night, they overflow into outpatient medical. And outpatient medical, when they're busy during the day, ER generally isn't. They flow to the left into the ER during the day. So we ended up building, instead of 24, 16 total rooms, 16 to 17, I think, saving about 7 exam rooms at 140 square foot per exam room. So that was thousands of square feet that was saved by figuring out operationally how they can get around their peak needs. So I thought that was a really cool solution that saved the client a boatload of money. And obviously, articulating and estimating costs is very important as well. We work with a lot of architects that help us with this, or actual builders that help us with this as well. And we provide our own insights. But you can see, these are a little bit old in terms of, and these are primarily additions and remodels. But like I was saying, net new square footage for hospital grade is 800 to 1,000 square foot right now. It's crazy. So now we're going to talk about financial affordability. I know this is the last section that I'm going to talk about, but it's really one of the most important. When we undergo a project like this is one of the first things that we do out of the gate is understand how much a client can afford. Because again, it's like when you go to buy a house, you go to a mortgage broker first to understand what you can afford. But this is a very important analysis. So it gives the client or the hospital an idea of how much additional debt that they can afford to take on to support a major building project. And sometimes it's not good news, honestly. Sometimes our clients will want to do something, but their financial affordability is zero. So then it becomes a different type of project then. So how do we improve the debt capacity? And there's ways that you can do that. You can improve service line growth. If you're a district hospital, think about a lid lift on the levies that the taxpayers are paying. And, you can try to reduce costs by cutting out service lines that are not accretive to the organization. So one of the things that allows critical access hospitals to even fathom building something is the fact that they can incorporate interest and depreciation into their expense structure, and that's reimbursed in cash. Without that, we would be in a much dire strait. And so that's why we are worried every year that this program is going to be terminated, not just from our perspective, but from our clients' perspective, because it really is a lifeline for them, especially those that are undergoing a construction project. This is an example of a client that was considering either a standalone ER internal renovation that was going to cost about $300,000. And there are also scenario 2 was an ER and an inpatient room renovation. So how this reimbursement critical access hospital program works is that it's based on a percentage of the patients that utilize that space that are Medicare. If you think about ER, it's not a heavily Medicare utilized space. So if you look at this particular client, the CFO was like, I really want to minimize how much we're spending. So I'm leaning towards the ED renovation only scenario. But when we ran the numbers through their cost report, they were only going to get reimbursed 77% of that $300,000 investment. 212 would be reimbursed through the critical access hospital program, and 62,000 would be unreimbursed. But when we added in scenario 2, the inpatient renovation, which increased the project size up to $500,000, but since inpatient was so heavily utilized by Medicare, 95% of that project was going to be paid for by the critical access hospital program. And you showed him those numbers. He's like, we're doing the big project. We're going to spend more, and it's going to be cheaper for us. That's what's wacky about the program. Like, if you don't look at this, your intuition says 300,000 is cheaper than 500,000. But the way the reimbursement program works, it actually makes a lot more sense to do the bigger project and get more bang for your buck and get more reimbursed through the critical access hospital program. So these are just some general ratios. Like when we work with USDA on a lot of these projects, we work with private banks, we work with PUD lenders that will be the ones financing these projects, the ones financing the debt. And they like to look at these three main ratios to tell credit worthiness, if you will. And probably the most important one is debt service coverage. So this is a hospital that, in 2022, debt service coverage, if you're not an accountant, is basically how much money you have to cover the debt that you have. So in 2022, they had 3.14 revenues to support 3.14 times the revenue to support the debt that they had. And then when their project hit in 2025, their debt service coverage ratio went way down because they took on a bunch of additional debt. But as you can see, it starts to go forward. The minimum number that USDA will accept for a low interest loan is about 1.25. So that's something that we try to get our clients to understand, because if you take on too much debt and your debt service coverage falls too low, then you start to violate covenants and you become a risk, and they can call in the note. Operating margin, obviously, this is something that's important as well, but a lot of hospitals have other outside investments that help with the operating margin number. So there's a lot of financing options out there. We talked about USDA, we talked about HUD. The good thing about USDA Community Facilities Loan Program is that it offers generally the best rates, but it's also a pain in the butt to go through. It can take months, sometimes years, or a year or more to get through. A lot of hurdles to jump through. We have the fortunate privilege to work with these programs a lot, and it can be very arduous process depending on the state that you're working through. And right now, honestly, USDA is a little bit of a mess with the current administration cuts and things like that. So it's even taking longer. So while you get a better rate, you can have to be waiting longer potentially to get the loan approved through USDA. So you could also go through, traditional bank financing, bond financing. There's a lot of, you can ask for additional funds from your community. Each option has its own pros and cons. So really having somebody walk you through that and discuss that will be very important as you decide how I'm going to get this financed. So I added some slides here at the end. There's a lot of detail. I'm not going to go through it, but a lot of our hospitals that kind of the last resort, if you will, are considering this rural emergency hospital program. Because if they can't afford to build something, they have low inpatient rates, and why not consider something like the REH program? And so we've started to do a lot more analysis for our hospitals that cannot afford to do something on their own and whether or not this would make sense for them. You have to be a current critical access hospital with 50 or fewer beds and be in a rural area and to have an active rural to qualify for this program. REHs have to provide 24-hour emergency services, lab services, diagnostics, imaging, pharmacy or a drugstore, and discharge planning by a qualified professional. And the average length of stay cannot exceed 24 hours. You can have certain patients that stay there beyond that, but the average cannot exceed that. They get an enhanced PPS rate for these hospitals, or for these REHs, which helps offset the loss of the cost-based reimbursement, but it depends whether or not that would make financial sense for them. And also, REHs are not eligible for 340B drug pricing. So that could be a deal breaker for many critical access hospitals that lose that. And then obviously, any hospital that would be currently operating an inpatient unit, we need to close that. So you'd have to distribute those staff at other places or terminate. So just wanted to talk a little bit about that because we do have clients that consider REHs as an alternative to building something that they can't afford. This is an example of a particular client that asked us to model out what this would mean to them. This is an example. You see there kind of the breakdown of, the additional payments for the REH, the additional subsidy for the 5%, but then you have loss of the 340B, loss of inpatient revenue. And for this particular client, it actually made sense for them, additional income. So this was something that they decided to pursue going forward, but this is not typical of every place. Like every organization that's considered this needs to do their own analysis to see whether or not it makes sense. So I just leave you with some pictures of clients that we work with that have gone through a replacement, and it can be a transformative thing for not only your patients but your community. The hospital on the right that looks like a castle a little bit, that's Kirby Medical Center in Monticello, Illinois. They were one of my first clients when I joined Wipfli back in 2005. And I worked with that CEO, and their hospital was 65 years old, and annual revenues were $14 million a year. What they had going for them was that they were 20 minutes outside of Champaign, Illinois, so pretty close to a larger city. So they're had much easier time recruiting providers, specialists, things of that nature. But we were able to work with HUD and get them into a replacement facility. It's about 75,000 square feet. And that was built back in 2012. And fast forward 13 years today, we've done 2 more master plans for them. They've expanded greatly, added providers, added orthopedic surgeons. They went from $14 million annually to $14 million a month. And they added a CrossFit gym, a wellness facility. They have a outpatient therapy building. And it's just been transformative for that community. You've seen their health metrics through their community health needs program go massively up. I'm very proud of that project, not only because it was one of my first ones, but one of the best things about my job is to see physically how a building like that can transform a community. So it inspires me to continue to want to help other rural providers across the country get to some place like that. It may not be a replacement hospital, but get to a place where they can meet their mission, which is providing healthcare to their rural constituents. So with that, I'll open myself up to questions. Yes.
Besides facility replacements or enhancements, do you also provide consultations for replacement of EMRs, which can be a pretty hefty uplift?
Yes, that is a service line that we can help evaluate those clients that are considering upgrading or replacing their current EMR. Yeah, and you're right. We've had projects that are delayed because all their money is going into their EMR upgrades. So it's kind of like, well, which one do we want to focus on? And then probably EMR makes a lot of sense too. So yeah, that is something that we can help with. Any other questions? Well, I appreciate your time. Thank you so much. And have a good rest of your conference.